A very good morning to all. So, we are going to start with our paper presentation. For that, we have our chairperson, Dr. Rajni Sharma. She is the additional professor, Division of Pediatric Endocrinology, Department of Pediatrics at All India Institute of Medical Sciences. And we have Dr. M. Vijay Kumar, professor and head, Department of Pediatrics, Government Medical College, Kerala. So we will have 10 minutes for each candidate. So at 6 minutes, the first bell will be there, and 8 minutes is for presentation and 2 minutes is for questions. So first candidate is, I think it's on virtual. First candidate is, no, sorry, is Winey Wayne.
Hello. Let me introduce, let me invite Professor Wayne Cutfield from New Zealand for the first presentation. And the topic is efficacy of fecal microbiome transfer in adolescent obesity, a 4-year follow-up. Over to you, sir.
Thank you, Vijay. Here are my disclosures. That's interesting. Here are my disclosures. At an earlier APIS meeting, we shared with you the results of our original gut bugs trial. And just to recap for you, what this involved was a double-blind randomized controlled trial in which we gave fecal microbiome transfers to obese adolescents. We recruited 87 14 to 18-year-old obese adolescents, and they were randomized to placebo or FMT. After a bowel cleanse, the patients were treated, the subjects were treated, and each FMT recipient received the microbiomes from 4 healthy super donors, and they were sex matched. The participants then underwent quite extensive evaluation, which include assessment of auxology, body composition, metabolic health, cardiovascular health, gastrointestinal health, and psychological well-being. In addition, we collected stool metagenomics on all donors and on all of the recipients at 6 weeks, baseline 6 weeks, 12 weeks, and 26 weeks. In terms of the treatment, it was effectively a single treatment over 2 days. The traditional method is to either to sedate the patient and perform a colonoscopy, take a stool, you've had your morning tea, blend it and pour it in through a colonoscopy. Alternatively, with a sedated patient, you can put a nasojejunal tube down and again pour in a blended stool into the patient's small bowel. Our participants wouldn't have tolerated that, so we developed a technique where we extracted from a fresh donor stool the microbiome, we cleaned the bacteria up, and then double encapsulated them so they could be swallowed as 28 capsules over 2 days. We're also able to store the capsules at -80 for up to 6 months, and they were still more than 70% viable. So our primary outcome was BMI at 6 weeks, and we didn't see a difference in BMI between the two groups, unfortunately. However, over the 6-month study, what we found is that those who had metabolic syndrome at the start of the study, in the FMT group, there was quite dramatic resolution of metabolic syndrome, with just 27% still having metabolic syndrome versus 83% in the placebo group. In addition, we showed a reduction in abdominal obesity as documented by DEXA-derived android-gynoid ratio. And equally importantly, we demonstrated that the donor microbiomes became engrafted in the recipients and remained so. They remained healthy, viable, and alive throughout the 6 months of follow-up. So recently, I asked the question, if we reassess these same participants 4 years later, is that engrafted microbiome they received after the single treatment, is it still engrafted, and are those bacteria still active? And those early metabolic improvements we saw, did they persist? Could they have gone away, or could they have in fact amplified? So we managed to find 2/3 of the original participants. And importantly, there was no difference between the 2/3 we found and the third that we couldn't locate. They were approximately equally distributed between the two groups, FMT and placebo, and approximately equally sex distributed. And they underwent the same assessment as they did earlier that I mentioned to you in the original study. Well, the first important thing is that those donor bacteria are alive and well. So you can see that if you look at the donor strains, the same proportion, the same percentage of donor strains were present at 6 weeks, 12 weeks, 26 weeks, and 4 years. So they're still there and they're still potentially active. And of course, you didn't see those donor strains on the right in the placebo-treated subjects. The placebo group, when we look over that 4-year period, they did as what you would expect many obese teenagers to do, in that there was this relentless march in their adiposity. So their weight continued to march up, their waist circumference continued to go up, and their total body fat continued to go up. When you overlay the FMT subjects, you see a very different pattern over that 4-year period. And you can see while the FMT group didn't lose weight over those 4 years, their weight didn't go up either, so that the difference between the two groups was in fact 10.6 kilograms, and their waist circumference was 8.2 centimeters less. That's a lot of belt notches. And they had 4.1% less total body fat. We also looked at metabolic syndrome, but we used metabolic syndrome severity score, which is a way of creating a continuous score of metabolic syndrome as opposed to the usual binary option, you either have it or you don't have it. And when we use a metabolic syndrome severity score, you can see that there was a reduction in metabolic syndrome severity score, and it was quite a lot lower than in the placebo-treated group. Now, of course, the question is, what's the relationship to the bacteria, donor or recipient, and response to treatment, metabolic syndrome and obesity? And you can see there are four panels there, and you can see that there are four bacteria there. I've taken the names of them off because unfortunately that's under IP registration at the moment, so I can't share those with you. But they are exemplars, and you can see that with changes in those bacteria, and I'd particularly like you to focus on the bacteria on the right, which is at 4 years, that there was a change in metabolic syndrome, a reduction with it, with high levels of that particular bacteria. So what does that mean, and where does that leave us? Well, to summarize, we've achieved sustained microbiome engraftment right out to 4 years after a single treatment. Remember, this is a single treatment. After 6 months, we saw reduced abdominal fat and a reduction in pre-existing metabolic syndrome. After 4 years, we saw much less weight gain, basically static weight, lower body fat, better metabolic syndrome severity scores, and I didn't show you the data because there wasn't time, better insulin sensitivity. We've currently identified, and I've shown you 4 exemplars, but we have others, of bacterial strains associated with improved outcomes. Now we're getting down to the gritty business of actually culturing up these of donor microbiomes, identifying from those microbiomes cultured up our key strains that we're interested in, and then mass culturing those to ultimately turn them into a super probiotic therapy, which we will then test and evaluate in rodents before going on to clinical trials. And with that, I'd like to thank your participation and our team who are on the slide. Thank you.
Thank you, Professor Wayne Cutfield, for that excellent presentation and maybe the future treatment of obesity in children. And I think 1 or 2 questions can be there from the floor.
That's fine, that was really great. I'm not familiar with the metabolic syndrome severity score, but I assume that it's been validated
Yeah,
to show improvements, as a predictive tool for outcomes.
it has.
In terms of the negative change, the change that you saw in the FMT group, how does that correlate with their long-term risk as predicted by that score?
That's a good question. I think the answer is we don't know, and the reason for that is that metabolic syndrome severity scores in terms of predicting long-term health are murkier than the traditional, you either have metabolic syndrome or you don't. The difficulty in doing that is it's quite a crude way of lumping and sorting patients out. That's why we used it as a continuous variable. We saw a similar difference with metabolic syndrome, but we use the severity score to basically tease participants out.
Wayne, really does a wonderful presentation as always. Can I just ask, there is a difference between males and females in terms of their microbiome. Did you see differences between the two groups in that?
The patterns, again, it wasn't possible to show you both the total and male and female data, but the same patterns were present in females. If anything, the improvements in metabolic syndrome severity score was slightly more in females, but not statistically different to males. Yeah, same.
So thanks a lot. Sorry for coming in late, but my question might be an expression of my ignorance in the field. If you isolate the bacteria from somebody who's on a Middle Eastern diet, which I love, versus somebody who's on typical American diet, versus someone who's on Indian diet, Indian food, what are the differences? And do you think you will have similar results?
Good question. So just to revisit what influences your gut microbiome, and basically, if you think about it very simply, diet is a big factor, and that's probably half or 2/3 of your dynamically changing microbiome. The other third is your established microbiome, and that's kind of what we're trying to tease apart. Of course, you can overlay diet and dietary changes, but effectively what we're trying to do is reset a disrupted or dysbiotic microbiome in these participants, in these, in our population. Now, coming back to your question about diets and ethnicity, is that we didn't find differences in the microbiome. So we had European, Māori, and Pacifica participants, and they didn't have their microbiomes were not dissimilar, and we all have a similar kind of diet. We haven't peeled apart vegetarian, for example, and non-vegetarian diets and donors. Yes, your diet will be an additive effect, but this is a factor that we are layering on and controlling. You can change your diet, and that will modify your microbiome. Think of this as a reset.
But a more pertinent question, how do you explain the less weight gain and the waist circumference decline and things like that? Is it changing energy? Is it changing absorption? Is it changing appetite? How?
Yeah. And possibly all of those things. And we know from animal studies that have been conducted, the effects of the microbiome occur at multiple levels, right from increasing or regulating the total absorbable calories, including short-chain fatty acids, which can be broken down and absorbed and can provide up to 200 extra kilocalories a day of calories. We've then got microbial products getting into the circulation, which are pro-inflammatory, obesogenic, can influence appetite. So the effects occur at multiple levels. So in our subjects, what has happened to them? Very good question, because we've got these two periods and this gap in the middle. What we did do, and I didn't mention, is we looked at their diets and activity levels, and they were different between the groups, so that hadn't changed. Mm-hmm. So it's quite possible that it's affecting multiple things, but what it is in those particular participants, but we can't say. But it's not going to be a single. It's not just appetite suppression. It's not just altered lipogenesis, which does occur.
Oh, thank you so much, sir. Time is up. I think, thank you so much for the presentation, sir. So the next.
Very interesting concept. I think there'll be a lot of questions after the session. Now we move on to the next one, which is online.
The topic is clinical significance of urinary NAG and blood cystine C in early renal damage, assessment of children with simple obesity. For this, I invite Dr. Haing Wu from China on virtual mode. By the time we contact her and arrange her presentation, I invite the next speaker, Dr. Alappan Mahapatra. He will speak on comparative accuracy of glycemic parameters in identifying dysglycemia in obese Indian children and adolescents. Over to you.
Hi, good morning everyone. Myself, Dr. Alapan, and thank you, APES 2024 and ISPE for giving me this opportunity to present my research work in front of you. So, as you all know, that obesity has emerged as a global public major health problem and across the globe. And recently, in IAP guidelines 2024, it has labeled as a chronic disease. With the increasing prevalence of obesity, the complications of obesity like hypertension, dyslipidemia, fatty liver disease, dysglycemia is also increasing. Dysglycemia is one of the major complications of obesity, accounting for around 15 to 20% of the cases. In our study published in 2015 in Indian Journal of Pediatrics, we found that our data is similar to the previous data. Almost 18% children were obese in our study. Not only that, the subsequent study in the 2024, which was published in Indian Journal of Pediatrics, we found that after a duration of 4 years, the type 2 diabetics in adolescent were much delayed presentation and have a rapid progression in comparison to the adults. Not only that, the initial insulin requirement as well as the latter add-on of the medication. So both the short-term outcome and long-term outcome, if we diagnose these patients at the screening, there is a better outcome. So the main aim was to diagnose this dysglycemia in the early stage and treat it properly. The options we have in our hand is the fasting blood glucose level, but it is affected severely by stress and illness, and there is a need for fasting, which is difficult for the children. There is 2 hours OGTT, which is a gold standard, but it has also the poor compliance. One less sensitive indicator was HbA1c, but it gives a good idea about 2 to 3 months of glycemic control, but affected by several non-glycemic factors, that is rapid rates blood cell turnover. Also, there are some racial and ethnic differences are present, and it needs to be standardized. So we have done our HbA1c from our NABL accredited lab using HPLC method with accordance to the DCCT control using the standardization of NGSP. Also, we have planned to see 10% patient on CGMS to see whether these patients are really correlating well with the fasting 2 hours OGTT and HbA1c level. This study was published in UK 2019 by Dr. Aniket, and he has shown clearly that being a less sensitive marker HbA1c, still it is very reliable in detecting type 2 diabetes, and he has advised to increase the cutoff to 6% to detection of the type 2 diabetes in this case. But there are certain Indian limited data available right now in our hand. So we have this aim, that we should want to compare the diagnostic accuracies of these glycemic parameters like fasting blood glucose, 2 hour glucose tolerance test, and HbA1c in identifying the pre-diabetes and diabetes in Indian children and adolescents. For this, we have included the obese children of 5 to 18 years, and obesity is defined as a Indian Academy of Pediatrics 2015 guidelines. Exclusion criteria were, we have excluded the pathological obesities, the syndromic obesities, drug-induced obesities. The initial baseline fasting level, 2 hours OGTT level, HbA1c, complication screening, bioimpedance, and the CGMS was our target. And after 1 year follow-up, we want to again repeat those tests to see whether there is any change in this parameter or not. We have a target total population of 250. We are right now in between the midway in our study, and we have almost 152 patients, among which 12 were excluded by exclusion criteria. So there are 140 Indian obese children with exogenous obesity, among which 62.8% were boys. This is a criteria from American Diabetes Association defining diabetes as well as pre-diabetes, and published in 2024. We have taken the cutoff of these guidelines to further proceed. These are the baseline parameters of our study, having a mean age of 12.6 plus minus 3 years and a BMI SDS of 2.4 plus minus 0.61. We have seen that 77% population of our study were pubertal, and they had a high mean OGTT and fasting blood glucose level in comparison to the HbA1c. Coming on to the results, and if we see the existing cutoff, the fasting blood glucose level and 2 hours OGTT detects pre-diabetes in 8 and 10 patients, where in case of HbA1c, it detects almost 19% patient of population, 27 patient. Not only that, by using one metric where it was diagnosing 27 patients, by using 2 or more methods, it diagnosed 8 and 2 patients respectively. Among these 27 patients who are diagnosed by prediabetes using existing cutoff by HbA1c, 21 patients were normal by other methods. That is almost 77%. And 6 patients were there who were positive by the other fasting or OGTT method. So this discrepancy had laid a question in our mind whether we are over-diagnosing these children. We are having this existing cutoff of 5.7 to 6.4. Not only that, in comparison to the 77% of normal population using the HbA1c as prediabetes, there are 30% and 37.5% were normal as defined by the normal by the fasting blood glucose as well as 2 hours OGTT level. In correlation with CGMS, we've also found that the average blood glucose level was 94 mg per dl in these children, and average blood glucose of CGMS correlates very well with fasting blood glucose level as well as 2 hours OGTT. But there was no significant correlation between HbA1c was found. So based on this 2 hours OGTT, we have taken that as gold standard and made a ROC cut to see what could be the appropriate cutoff, and we found that a cutoff of 6% having an area under the curve of 0.860 and which have a better specificity in comparison to the existing cutoff. This is study done in the UK and it was seen that the HbA1c has racial and ethnic variations. Still, they had proposed that the mean HbA1c concentration in Asian population is around 6%. So early identification is very necessary to prevent this dysglycemia in children, and probably we need a higher cutoff to see in that, and we definitely need some follow-up data to see whether this raised cutoff is going to diabetic or they are becoming normal. And we hope that ABGM could be a potent tool in future to diagnose dysglycemia in children. The limitations measure were in our study that we still don't have our follow-up data, and only 10% patient we can put on CGMS due to some financial constraints, and this is a single center based study. I'd like to thank Dr. Anurag Bajpayee sir for his constant support, and team Regency, CDER, Dr. Bibha, Dr. Dhani, and Manoj sir for his support. Thank you.
Thank you, Dr. Alapan. Any questions from the audience? Yes.
Thank you very much. And this is more a comment than a question, actually. I think it's really interesting that, you know, a relatively simple test like hemoglobin A1c is so useful. And you know, in the type 1 diabetes area, people look so hard for signs of progression in early type 1 diabetes, and actually hemoglobin A1c is coming up trumps even more than OGTT at the moment, is something else. So it's really interesting in type 2 children as well. It's still a very useful
And children with short stature also presented with DST, delayed puberty, Mosaic-Turner syndrome, and obesity. So the key message is children with genetic disorders have variable endocrine presentations. Therefore, karyotyping should be considered in endocrine patients to find out these rare conditions.
I'll try and talk over the other speaker. I'm really good at that. Thank you. It was a lovely presentation. I have 2 short questions. The first is, obviously, things like anemia, hemoglobinopathies can modify your hemoglobin A1c. In your group, do you know how many, what the percentage of anemia, iron deficiency or otherwise you had, because that may modify your response? And the second one is, other parts of the world have shown subtle but definite differences in HbA1c with season. Did that make any difference at all either?
Sir, we have done all the baseline parameters in these obese children, and we found there is no significant discrepancy in terms of the hemoglobin level, liver function or renal function was present in that study. And the second question, obviously we have taken for 6 months and there is obviously seasonal variation. We have not considered the seasonal variation in our study right now.
Can you mention some causes of false positive HbA1c?
Yes, ma'am. False positive HbA1c. If the turnover is more, like in polycythemia, we can have HbA1c more.
Okay. Basically, anemia and hemoglobinopathies, they can cause false positive. Thank you.
Thank you.
We move on to the next session. Do we have her online? Okay. So the next session is clinical significance of urine and acetylglucosamine and blood cystatin C in early renal damage in children with simple obesity. So for that, we have Dr. Haiying Wu from China.
Good afternoon, dear college. I'm Haiying Wu. I'm from Children's Hospital of Suzhou University of China. My topic is clinical significance of urine NAG and serum CYC in early renal damage assessment of children with simple obesity. Background: overweight and obesity are independent risk factors of CKD and ERSD, and kidney disease is the most important factor affecting mortality in adults, and early kidney damage can occur in childhood. The study on the prevalence of obesity and the relative complications in China point out that the complications of chronic kidney disease account for 4.1% in overweight children and 6.3% in obesity patients. According to statistics, the obesity rate of children and adults is rising faster among all age groups. ORG is clinical characterized by stable or slowly progressing proteinuria. The gold standard for diagnosis is kidney biopsy. The rate of kidney biopsy in patients with obesity combined with proteinuria is extremely low, so it is necessary to find a biological marks for early, convenient, and acute diagnosis of ORG. Study content from October 2021 to January 2024. 302 children with simple obesity were selected, and 53 children with similar age who went to the Department of Child Health Care for our hospital during the same period were selected as the normal control group. Clinical data of two groups, including basic data, blood, and urine test results were collected to compare the difference in clinical data between the obesity group and the normal control group, and to analyze the correlation between serum CYC, urine NAG, and renal function. 302 children with simple obesity were divided into albumin group and without albumin group according to UACR. The difference of general clinical data and laboratory parameters among the albumin group and without albumin group were compared. Multivariate logistic regression analysis were used to find out the predictors for kidney damage, and ROC curve were used to verify them. The group were divided according to different degrees for obesity. Among them, mild to moderate obesity, 110 cases, severe obesity, 192 cases, according to the URCE level grouping. USCR level than 13 milligram per gram for obesity without albumin gram, a total of 288 cases. UACR greater than or equal to 13 milligram per gram for obesity, albumin group, a total of 40 cases, of which the normal control group, a total of 53. According to the cause of obesity, among them, 0 to 2 years, 91 cases, 2 to 5 years, 167 cases, greater or equal to 5 years, 44 cases. Results and discussions. Comparison of serum CYC, UNAG, and UACR between the obesity group and the normal control group. There was significant statistical difference in CYC and UNAG, but no statistic difference UACR. The UNAG and CYC levels in children with simple obesity were higher than those in normal control group, indicating that the early kidney damage may occur in children with simple obesity. Comparison of the serum CYC, UNAG, and UACR in different causes of obesity and the normal control group. There was significant statistical difference between CYC and UNAG. UACR value increased gradually with prolongation of disease course, but the difference did not reach statistical significance. It would suggest that the longer the course of obesity, the higher the possibility of early kidney damage in patients with simple obesity. Comparison of UNAG, CYC, and UACR in obese and non-albumin group, there was statistical difference in UNAG and UACR between the two groups, and the average level of CYC was higher than that of the obesity group without albumin, but it has not reached statistical significance. In the corrections analysis of obesity albumin group, UNAG and UACR shows some moderate positive correction, while CYC and UACR had no correction. Therefore, in this study, CYC was not the best biomarker for the predicting for early renal injury in sisters. The correlations between the small number of cases in the obesity albumin group. Multivariate logistic register analysis of early kidney damage in children with simple obesity. UNAG is an independent influence factor for early renal injury in children with simple obesity. CYC single test could not independently diagnose ORG. The combined detection of UNAG and CYC had the highest UAC, higher specificity and sensitivity, 75% and 85.7%. The single detection of UNAG show higher sensitivity and specificity, 71.4% and 81.9%, and the package point value was 16.065. Conclusions: the levels of UNAG and CYC in children with simple obesity are higher than those in normal healthy children, suggesting that early kidney damage may occur in children with simple obesity. UNAG was moderately or possibly correction with UACR, suggesting that UNAG may be a good predictor for prediction early kidney damage in children with simple obesity. UNAG is an independent influence factor of early kidney damage in children with simple obesity. The combine of UNAG and CYC has a certain value in the assessment of early kidney damage in children with simple obesity, and the combined detect of UNAG and CYC is superior to the single detection of UNAG. Thank you for your listening and kindness.
Thank you for the wonderful presentation. Now the floor is open for discussion. 1 or 2 questions, please. And not online.
We played her recorded presentation. She has sent a mail that she will not be able to join.
Okay. She joined?
No.
Hello. Oh, thank you for that very interesting talk. From a nephrological perspective, my understanding is that in the absence of clinical markers such as hypertension or albuminuria, that there is currently no evidence for the use of these early markers to change management or to change outcomes. And I wondered whether you could comment on how you think that these findings might inform what we would do in the clinic or what further work might need to be done from here.
No. She's not. I think.
Who's asking the question? She's asking.
I think We can
Actually,
move on to the next.
she has sent a mail that she would not be able to
Yeah.
join online. That's
very
another
good question
purpose.
because we really don't know how it's going to affect the long term, and is it really a good marker for kidney injury? These markers.
So it's a marker of early tubular damage, but there's not been, to my knowledge, any evidence yet that there is a role for doing anything clinically in terms of treating nephropathy before you have hypertension or albuminuria.
Could have correlated with hypertension. The data that you showed.
Okay, we can
We
go
can
for the
take the
next
next speaker,
next
yes.
thing. Dr. Chirantab Oza, your talk is local versus international anthropometric parameters for assessing overweight, obesity, and metabolic syndrome in children of South Asian and Southeast Asian countries. The floor over to you, Dr. Chirantab.
Thank you so much, sir. So, as the title of the study suggests, we conducted this study in 2 phases. The first part of it was done in a South Asian country, that was India, in Pune, under the guidance of Dr. Vaman Khadilkar and his team. And the second part of the study was conducted in Southeast Asia. It included Indonesia and Thailand. And I have enlisted the co-authors here, predominantly Dr. Aman Pulangan from Indonesia and Dr. Sutipong Vacharasindhu from Thailand. Their teams worked in collaboration with us, and the important results of this study I'll be presenting right now. So here, as we can see, this is the map of Asia. The region that is labeled in red is South Asia, and the region that is colored in blue is the Southeast Asia. As we can see, these regions account for around 1/3 of total world's population. And this is the data on overweight and obesity. So it shows that from 1990 to 2022, the prevalence of overweight and obese has increased from 8% to 22%. Specifically for obesity, the increase is from 2% to 8%. So as per the World Health Organization statement in 2022, 1 in 8 people live with obesity. This includes 160 million children of age 5 to 19 years. The rise has occurred similarly in both the genders, roughly around 20%. And as we know, childhood obesity is associated with a greater risk of cardiovascular diseases and has adverse psychosocial consequences, thereby making its identification early for early intervention important. So there are various guidelines for obesity. So the Indian guidelines I have put in this slide. So the Indian Academy of Pediatrics has put guidelines on evaluation, prevention and management of childhood obesity, and some of our esteemed senior colleagues that are present here have been a part of this guidelines. So I can say Ahila ma'am, president of ISPE, was a part of these guidelines. So the one thing that they mentioned here was that the Asian population tends to have adiposity and increased cardiometabolic risk at a lower BMI. So the definition of obesity, there are various definitions, like the CDC defines it as BMI of more than 95th percentile for age and sex, while the World Health Organization defines it as 2 standard deviation above the WHO growth reference median. The IOTF labels it as adult equivalent for 25 and 30 kg per meter square BMI, while the Indian Academy of Pediatrics defines the cutoffs at 23rd adult equivalent for overweight and 27th adult equivalent for obesity. So the question that becomes is, to define obesity by BMI, which definition should be used? So here is some comparison. So as we can see, when the WHO or IOTF or the CDC definition was used, the prevalence of overweight and obesity in Vietnam, Indonesia and India was slightly lesser as compared to when the local reference growth charts were used. So in context of India, as we can see, when the WHO definition was used, 15.7% of children were overweight or obese. But when the Indian Academy of Pediatrics definition was used, 19.10% children were labeled as overweight or obese. So as a general statement, I can say that international growth standards underestimate the prevalence of obesity when used for classification in children of South Asia and Southeast Asia region. So which definition to use? Is there an objective way to do it? So we conducted this study to assess the predictive value of a national, regional and international growth reference in identifying metabolic risk in subjects classified as overweight or obese. So as we can see, the study group from India included 875 children, and from the Indonesia it included 2,526 children that were a part of their Indonesian family survey, fifth wave. We used Pakistani BMI reference charts for comparison with the Indian children, and we used the reference data from Thailand to compare the Indonesian children. So as we can see in this table, for Indian data, country-specific growth chart were the Indian Academy of Pediatric growth charts. For a country from same region, we used Pakistan. For a country from different region, that is from Southeast Asia, we use the Indonesian National Synthetic Growth Chart. And for international references, we use the WHO growth reference. Similarly, for Indonesian data, national from a different region and international were the same. Just from the same region, we used 2021 Thai reference from 6 to 19 years for height and weight. And metabolic risk was defined as presence of one of the following, that is high waist circumference, high fasting glucose, or high blood pressure. So we took clinical history, including blood pressure measurement, anthropometry that included height, weight, and waist circumference measurement, and in biochemistry, we took the fasting blood glucose level. Some of the research conducted by our group in this field is that we have shown predictive value of WHO and IAP BMI charts for identification of metabolic risk in Indian children. And we have also shown by field testing of synthetic growth charts for 1 to 60-month-old Indian children that there is a certain amount of significant variation in terms of underestimation of obesity and overestimation of stunting when international references are used for Indian children. So for the present data set, the mean age of the study group was 11.5 years. The mean body mass index was 16.6. And we computed the Z-scores, and the mean Z-scores for BMI for age are presented in the table. In this graph, we show the correlation between various pairs. So as we can see, the Southeast Asia and South Asia, when compared with the WHO BMI for age Z-scores, had the lowest correlation coefficient, that was around 0.5 to 0.6. When South Asia and Southeast Asia BMI Z-scores were compared, the correlation was 0.7. And for amongst South Asia countries, that is between India and Pakistan, and for Southeast Asia countries, that is Indonesia and Thailand, the correlation coefficient was 0.9. This table shows the sensitivity, specificity, negative predictive value and positive predictive value of various growth references in identifying metabolic risk. And as we can see, the comparison for Indian data, the World Health Organization, the WHO growth chart has the lowest sensitivity, but the specificity is comparable. Then we computed the Uden index, which is calculated as sensitivity plus specificity minus 1. And as we can see, for Indian data, the national growth chart had the highest Uden index, followed by of the country of same region, followed by the country of another region, and followed by the international growth reference. Similar results were obtained for the Indonesian data as well. So this was first of its kind study to objectively report accuracy of various growth references and their overweight obesity cutoffs in predicting metabolic risk for pediatric population of South and Southeast Asia region. But lack of data on lipid profile and different techniques used in generating these references and lack of uniformity in defining overweight and obesity cutoffs were some limitations. In conclusion, local anthropometric growth reference data are more accurate in identifying overweight and obesity. The WHO growth references classifies overweight or obese children at metabolic risk as normal. So there is a high rate of false negative. So targeted early intervention might not happen if we use the WHO BMI for age cutoffs. For countries that do not have an anthropometric growth reference data, the reference data from the country of same region may be more appropriate. Finally, it may be prudent to develop growth charts based on ethnicity, geographic region, rather than a single international growth reference. Thank you so much for your kind attention.
Thank you, Dr. Chirantap. Any questions from the audience? So what you're trying to say is that the Indian standards, they identify metabolic risk better.
Yes.
Compared to, they have better sensitivity.
Yes.
And for Indian children as
For
well as
Indian
Thailand.
children, yes.
And what were the limitations of your study?
We did not get the lipid profile done. So there are 5 parameters in definition of metabolic syndrome: waist circumference, blood pressure, fasting glucose, HDL level of less than 40 or 50, and triglyceride level of more than 150. So we could not get the lipid profile. So 2 parameters were missing. So we could not define metabolic syndrome properly. So if any one of the other 3 risk factors was present, we labeled it as metabolic
And
risk and used that
How
as
do you define waist circumference?
more than
abdominal?
90th centile for age and sex using the Indian data for Indian children and the Indonesian data for the Indonesian data set.
Any more questions? Thank you, Dr. Chirantha.
Thank you so much. Thank you.
Next, we have Dr. Ji Won Park from Korea. Is he there? Okay, sorry. She's there. And her topic is prevalence of obesity and overweight children in South Korea before and during COVID-19 pandemic.
Hello everyone, my name is Jiwon Park from South Korea. Today I would like to talk about the change in prevalence of obesity and overweight children in Korea before, during, and after COVID-19. Okay. Over the past decades, the prevalence of overweight and obesity in children has shown. So over the past decades, the prevalence of overweight and obesity in children has shown a steadily increasing trend, but has generally stabilized from the early 2000s, but the portion for extreme obesity has increased. The outbreak of COVID-19 from the late 2019 resulted in school lockdowns, and previous studies have shown a shifting trend in normal weight to overweight or obesity, and an exceptional aggravation of BMI elevation during this period. Korean National Health and Nutrition Examination Survey is a nationwide cross-sectional survey conducted by the Korean Centers for Disease Control and Prevention. The survey is conducted by selecting randomized subjects and includes survey, anthropometric measures, and biochemical data collection from fasting blood samples if the participant is over 10 years. This study aims to analyze changes in the prevalence of overweight and obese children in South Korea during 2019 to 2022, including the COVID-19 pandemic period, and investigate the contributing factors for the observed changes. This study incorporated data for children aged 2 to 18 years from the survey 2019 to 2022, which includes before, during, and after COVID-19. Year 2022 is classified as after COVID-19 as regulations regarding the pandemic has eased from the early 2022 in Korea. The classification of weight status is made under the KCDC criteria, and the variables incorporated in the study was BMI, BMI SDS, classification of weight, attempt to lose weight, and sedentary time. For statistics, survey weights were taken into account and weighted linear regression analysis was performed. Now moving on to the results. There were a total of 4,377 final subjects, and the baseline characteristics were similar among 4 years. The mean BMI and standardized BMI of total children show a steadily increasing trend during COVID-19 pandemic period from 2019 to 2021. This increasing trend in mean BMI stabilized after the pandemic period, but mean standardized BMI shows a decreasing trend after COVID-19, which was more prominent and statistically significant in boys. Additional analysis was carried out by setting new categorical variable by setting 2019, 2020 to 21, and 2022 for before, during, and after COVID-19. The mean BMI of total children increased by 0.29 during COVID-19 and stabilized after the pandemic as previously mentioned. And standardized BMI increased by 0.13 during the pandemic, but decreased by 0.26 after COVID-19. The decrease in standardized BMI after COVID-19 was observed in all groups except for girls of 10 to 18 years and was most prominent in boys of all ages, in which the decline was 0.26, although not statistically significant. The prevalence of total overweight children showed a steadily increasing trend from 10.2% before COVID-19 to 11.5% after COVID-19. And the prevalence of total obese children corresponded with the rise in overweight prevalence during COVID-19. The prevalence of obesity in total children showed a statistically significant increase from 12.4% before COVID-19 to 16.0% after COVID-19, and marked increase in prevalence of obesity and extreme obesity was observed in 10 to 18 years boys, with 7.1% increase in obesity prevalence and 4.9% increase in extreme obesity. However, the prevalence of obesity showed a declining trend after COVID-19, decreasing from 16.0% during the pandemic to 13.8% after COVID-19, although the finding was not statistically significant. The same data on the graph shows an overall increase in overweight children in the age group of 10 to 18 years, but no statistically significance was observed. On the other hand, the prevalence of overweight 2 to 9-year boys started to show a decreasing trend after COVID-19, but this finding was also not significant. For obesity, there was an increasing trend in obese boys of all ages during COVID-19, but there was no significance, and the prevalence started to decrease after the pandemic period. While most children showed a decrease in obesity prevalence in 2022 after COVID-19, girls of 2 to 9 years manifested a statistically significant increase in prevalence of obesity from 7.9% in 2021 to 14.5% in 2022. A comparison of lifestyle factors during and after COVID-19 in adolescent boys and girls of 12 to 18 years shows that mean sedentary time has increased after COVID-19, with girls having a longer sedentary time. In addition, the number of total girls who attempted to lose weight has decreased from 41.12% before COVID to 33.63% after COVID-19, where the number of overweight boys attempting to lose weight has increased from 26.7 before COVID-19 to 31.05 after COVID-19, which could have contributed to the rapid decrease in prevalence of obesity in boys of 10 to 18 years during this period. To summarize, the mean BMI and BMI SDS and the overall prevalence of overweight and obesity showed a marked increase during the pandemic period, and it was more prominent in boys, which is coherent with previous studies comparing the prevalence of obesity between boys and girls. A distinct increase in the prevalence of obesity and extreme obesity in boys of 10 to 18 years was most prominent during the pandemic period. Prevalence of overweight boys 10 to 18 years stayed relatively stable, while obese and extremely obese boys manifested a significant increase. This could imply a trend of previously normal weight or overweight boys rapidly shifting to obesity during the COVID-19 period. Mean BMI, SDS, and overall prevalence of obesity start to show a decreasing trend after COVID-19 related regulations have been eased. Girls of 12 to 18 years had increased sedentary time and lower rates of weight loss attempts after the pandemic compared with boys of the same age group. Differences and changes in BMI and the prevalence of overweight and obesity regarding the gender could be arising from societal expectations and established norms regarding the gender roles. Therefore, there should be gender and age-specific interventional methods targeting pediatric obesity. In conclusion, the overall prevalence of overweight and obesity among Korean children, along with mean BMI, increased from 2019 to 2021, with marked elevation during the COVID-19 pandemic period, and started to show a decreasing trend as regulations were eased after the pandemics. Further analysis, incorporating data from subsequent years of KNH-NES, is required to better understand the trend of pediatric obesity following COVID-19, where usual lifestyle patterns are recovered. Selective approaches by lifestyle modifications are required to effectively manage childhood obesity due to the differences in the prevalence of obesity regarding gender and age. Thank you for your attention.
Thank you. It was a nice presentation. And the floor is open to 1 or 2 questions.
Nice presentation. And you mentioned that the data you showed has been seen in a number of other countries. What would be interesting to know, and what hasn't been dissected out, is the total number of weeks of reduced ability to move around. In other words, restricted activity at home or other restrictions. Can you tell us what restrictions there were in South Korea? Because when we think about the COVID year, when you actually think of the total number of restricted weeks, it's not a huge number that's led to this change in BMI. So can you tell us that?
For example, during the COVID-19, the restrictions were basically the children were homeschooled. They didn't.
Do you know how many weeks of that occurred? And was some of it government restrictions?
It was more than a year.
It was more than a year.
Yeah,
so children stayed at home for more.
Stayed at home. They did online schooling through various methods and the children were also not allowed to get along. They were not allowed to make groups more than 3 people, so they weren't able to play outside together, and they were also restrained from going to indoor play areas as well. So the overall physical activity time has greatly decreased during this period, and even after the regulations have eased, the amount of screen time or sedentary time hasn't started to decrease again. So we would need to see further data to see how much years would take for the children to recover to their lifestyle before those regulations were formed. And
a whole year to stay at home with their best friend in the refrigerator.
Well, it depended a little bit according to which city or areas they lived, but yeah, basically over a year. Yeah.
It's very interesting that the girls did not lose weight. Any reason for that? The boys?
I guess it probably has to, like I mentioned, it probably has to do something with the gender roles. Like boys, typically thinking about it, boys would have more physical activity when there were no regulations, but girls maybe because even at schools, they do not participate well in physical activities during school time. So that might have affected the girls requiring more time to become more active. Yeah.
Yeah. I think boys might have started physical activity a bit earlier. So the next is Professor Yu Yang Chen from China, that is from virtual mode. The topic is genetic etiology and clinical phenotype of childhood obesity based on whole exome sequencing technology. Over to you, Professor Yu Yang.
It's a great honor to be here to share our work about genetic etiology and the clinical phenotype of childhood obesity based on the whole exome sequencing technology. We are from Jiangxi Prevention Children's Hospital, China. I declare that I have no potential conflict of interest. We will report our work in 4 parts. Part 1. Background. As we know, the child and adolescent obesity is a serious and urgent public health issue worldwide. The prevention of children's obesity has reached 5.6% in 2016, and according to our Chinese data, this will reach to 8.9% according to a study in 2017 to 2019. As we know, there are many genes in obesity studies, such as monogenetic and polygenetic. And the monogenetic obesity typically manifests in early childhood, often before the age of 10 years old. Most of the genetic genes were involved in the leptin-maltodextrin pathway. Field of the study examined the genetic etiology of non-syndromatic obesity in Chinese population. So, this study was investigate the genetic and clinical phenotypes of the monosyndromic obesity through the whole exome sequencing in a cohort of 392 obesity children. Part 2. Method. The study was approved by the ethics committee of our hospital. The inclusion criteria: participants were aged between 7 to 14 years old, with the onset of obesity before the age of 10 years old. And the diagnosis criteria were based on the contents of Chinese. And the exclusion criteria and obesity with syndromes such as just stature, intellectual disability, hearing disorder were all excluded, and the drug-induced obesity we also include. And we screened the 78 candidate genes for obesity. As3 results. And among the 392 children with non-central obesity, there were 302 boys and 19 girls. In our study, 32 obese children, which was 8.4%, were found to carry 18 non-syndromic obesity genes. The UCP3 and the MC4R gene were the most common. 7 cases, which was 1.8%, were classified as likely pathogenic by ACMG rating. 1 was male and 6 were female. The positive rate of the girls was 6.6%. And in the 7 cases, 3 carried the MC4R gene, which was the most clear pathogenic and most common in our data. Among the 3 cases of the MC4R gene, 2 cases carried the mutation of 494. Among the patients with ACMG rating FLP, 5 cases had advanced bone age, family history, insulin resistance, and 4 cases with precocious puberty. Part 4. Conclusion. The UCP3 gene was associated to severe obesity and type 2 diabetes. In our study, found that UCP3 gene had the highest screening positive rate in childhood and adolescent obesity, accounting for 18%. UCP3 carriers are prone to have obesity complications earlier, such as liver dysfunction, hypouremia at advanced bone age, significantly increased urine microalbumin, and insulin resistance and other symptoms. And for the MC4R, variants contribute to the early onset obesity in papers. And in our study, 4 patients carried the MC4R gene mutation. 3 patients were rated to LP and 2 patients were with the mutation of 494. The 4 children had severe obesity, family history of the obesity, and hypotriglycemia, and all showed obesity phenotype before the age of 6 years old. Summarize. The study found that the lack UCP3 and MC4R gene are the most common genes of the non-syndromic obesity in children and adolescents. More attention should be paid to severely early onset obesity girls. The obese patients who had complications earlier, such as liver dysfunction, which may be a clinical clue to consider whether to conduct a genetic screen in the future. Thank you.
Thank you, Dr. Yu Yang. Is she online? Okay. So, questions from the audience? So, we would like to know what was the inclusion criteria, because it seems many of these patients also had simple obesity. Did you use any inclusion criteria as in terms of BMI, body mass index?
Yes, we use BMI. And we have Chinese stature, so we use the Chinese BMI for this study.
Okay, what BMI cutoff did you use? Was it
for the we have a BMI for every age, so it's different for every age.
So even the ones with mild obesity or grade 2 or grade 3, anything like that?
Yes.
Okay.
We have a schedule for the Chinese population, so it's a table.
Okay. Thank you. You would
Thank
like
you.
to ask any questions? Okay. Thank you so much. So we can wind up this session now. Okay. Thank you very much to the organizers and participants. Thank you.
Thank you everyone for joining us. I would request Dr. Subroto Dey to please felicitate our chairpersons. I request you all to have a look at the posters downstairs and encourage our investigators while the lunch is getting ready.